I will be discussing about the elbow and the shoulder. The elbow. The elbow helps position the hand in space and stabilizes the lever action of the forearm. The elbow joint is formed by the humerus and two bones of the forearm, the radius and the ulna. These bones have three articulations: the humero-ulnar joint, the radio-humeral joint, and the radio-ulnar joint. All three share a large common articular cavity and an extensive synovial lining. The muscles traversing the elbow includes the bicep and brachioradialis for flexion, the brachialis and tricep for extension, the pronator teres for pronation, and the supinator for supination. Note the location of the olecranon bursa between the olecranon process and the skin. The bursa is not normally palpable but swells and becomes tender when inflamed. The ulnar nerve runs posteriorly in the ulnar groove between the medial epicondyle and the olecranon process. The radial nerve is adjacent to the lateral epicondyle. On the ventral forearm, the medial nerve is just medial to the brachial artery on the antecubital fossa. Techniques for examination includes inspection and palpation and will be further discussed in the video later. Tenderness distal to the epicondyle is common in lateral epicondylitis or tennis elbow and less common in medial epicondylitis or pitcher or golfer's elbow. The olecranon is displaced posteriorly in posterior dislocation of the elbow and supracondylar fracture. Range of motion and maneuvers. Range of motion includes flexion and extension at the elbow and pronation and supination of the forearm, which also move the wrist and hand. After injury, preservation of active range of motion and full elbow extension makes fracture highly unlikely. Full elbow extension has a sensitivity of 84% to greater than 98% and a specificity of 48% to greater than 97% for absence of fracture. Tenderness over the radial head, olecranon or medial epicondyle, and bursing, plus absent elbow extension may improve these tests' characteristics. Full elbow extension also makes intra-articular effusion and hemarthrosis unlikely. This table shows the range of motion, specifically elbow movement, primary muscles affecting the movement, and your patient instructions. The shoulder. The glenohumeral joint of the shoulder is distinguished by wide-ranging movement in all directions. This joint is largely inhabited by bony structures. The humeral head contacts less than one-third of the surface area of the glenoid fossa and essentially dangles from the scapula attached by the joint capsule, the intra-articular capsular ligaments, and the glenoid labrum, and the meshwork of muscles and tendons. The shoulder derives its mobility from a complex interconnected structures of three joints, three large bones, and three principal muscle groups, often referred to as the shoulder girdle. These structures are viewed as dynamic stabilizers, which are capable of movement, or static stabilizers, which are incapable of movement. This muscular meshwork can make it difficult to distinguish shoulder from neck disorders. Dynamic stabilizers. These consist of the sits muscles of the prorotator cuff, supraspinatus, infraspinatus, teres minor, and subscapularis, which moves the humerus and compress and stabilize the humeral head within the glenoid cavity. Static stabilizers. These includes the bony structures of the shoulder girdle, the labrum, the articular capsule, and the glenohumeral ligaments. The labrum is a fibrocartilaginous ring that surrounds the glenoid and deepens its socket, providing greater stability to the humeral head. The joint capsule is strengthened by tendons of the rotator cuff and glenohumeral ligaments, adding joint stability. The bone structures of the shoulder include the humerus, the clavicle, and the scapula. The scapula is anchored to the axial skeleton only by the sternoclavicular joint and inserting muscles often called the scapulothoracic articulation because it is not a true joint. There are three different joints that articulate the shoulder: the glenohumeral joint, the sternoclavicular joint, and the acromioclavicular joint. The glenohumeral joint, this is a joint the head of the humerus articulates with the shallow glenoid fossa of the scapula. This joint is deeply situated and normally not palpable. It is a ball and socket joint allowing the arm its wide arc movement, flexion, extension, abduction, movement away from the trunk, adduction, movement toward the trunk, rotation, and circumduction. Sternoclavicular joint. The complex medial end of the clavicle articulates with a concave hollow in the upper sternum. The acromioclavicular joint. The lateral end of the clavicle articulates with the acromion process of the scapula. This picture shows the different joints, particularly the acromioclavicular joint, the glenohumeral joint, and the sternoclavicular joint. Three groups of muscles attached at the shoulder. The scapula-humeral group. This group extends from the scapula to the humerus and includes the muscles inserting directly on the humerus, namely the sits muscles of the rotator cuff, supraspinatus that runs above the glenohumeral joint and inserts on the greater tubercle, the infraspinatus and teres minor that cross the glenohumeral joint posteriorly, insert onto the greater tubercle, and the suprascapularis, which originates on the anterior surface of the scapula and crosses the joint anteriorly, inserts on the lesser tubercle. The scapular-humeral group rotates the shoulder laterally, the rotator cuff, and depresses and rotates the head of the humerus. The axioscapular group is a group that attaches the scapula to the trunk and includes the trapezius, rhomboids, serratus anterior, and levator scapula. These muscles rotate the scapula and pull the shoulder posteriorly. This picture shows the two groups, particularly the axioscapular group and the scapulohumeral group. Axiohumeral group. This group attaches the humerus to the trunk and includes the pectoralis major and minor and the latissimus dorsi. These muscles rotate the shoulder internally. The biceps and triceps, which connect the scapula to the shoulder of the forearm, are also involved in shoulder movement, especially forward flexion of the biceps and extension of the tricep. Also important to shoulder movement are the articular capsule and bursae. Surrounding the glenohumeral joint is a fibrous articular capsule formed by the tendon insertions of the rotator cuff and other capsular structures. The loose fit of the capsule allows the shoulder bones to separate and contributes to the shoulder's wide range of movement. The capsule is lined by a synovial membrane with two outpouchings, the subscapular bursa and the synovial sheath of tendon of the long head of the biceps. To locate the bicep tendon, rotate your arm externally and tubercle. Roll it under your fingers. This is the tendon of the long head of the biceps. It runs in the bicipital groove between the greater and lesser tubercles. The principal bursa of the shoulder is the subacromial bursa, positioned between the acromion and the head of the humerus and overlying the supraspinatus tendon. Abduction of the shoulder compresses this bursa. Normally, the supraspinatus tendon and the subacromial bursa are not palpable. However, if the bursal surfaces are inflamed, subacromial bursitis, there may be tenderness just below the tip of the acromion, pain with abduction and rotation, and loss of smooth movement. This is a picture showing the several tendons and muscles and bursa explained previously. The techniques for examination for the shoulder also includes the inspection and palpation. In inspection, scoliosis may cause elevation of one shoulder, With anterior dislocation of the shoulder, the rounded lateral aspect of the shoulder appears flattened. Atrophy of the supraspinatus and infraspinatus with increased prominence of scapular spine can appear within 2 to 3 weeks of the rotator cuff tear. Infraspinatus atrophy has a positive likelihood ratio of 2 rotator cuff disease. Swelling from synovial fluid accumulation is rare and must be significant before the glenohumeral joint capsule appears distended. Swelling in the acromioclavicular joint is easier to detect as the joint is more superficial. Localized tenderness points the subacromial or subdeltoid bursitis, degenerative changes or calcific deposits in the rotator cuff. Swelling suggests a bursal tear that accumulates with the articular cavity. Supraspinatus directly under the acromion, infraspinatus posterior to the supraspinatus, teres minor posterior and inferior to the supraspinatus, and subscapularis that inserts anteriorly and it is not palpable. The fibrous articular capsule and the broad flat end tendons of the rotator cuff are so closely associated that they must be examined simultaneously. Swelling in the capsule and synovial membrane is often best detected by looking down on the shoulder from above. Palpate the capsule and synovial membrane beneath the anterior and posterior acromion to check for injuries or arthritis. Tenderness over the sits muscle insertions and inability to abduct the arm above the shoulder level occurs in sprains, tears, and tendon rupture of the rotator cuff, most commonly in the supraspinatus. To examine the subacromial subdeltoid bursae and the sits muscles, first, passively extend the humerus by lifting the elbow posteriorly, which rotates these structures so that they are anterior to the acromion. Palpate carefully over the subacromial and subdeltoid bursae. Underlying palpable sits muscles, which includes the 4 sits muscles previously explained, the fibrous articular capsule and the broad flat end tendons of the rotator cuff are closely associated that they must be examined simultaneously. Swelling in the capsule and synovial membrane is often best detected by looking down on the shoulder from above. Palpate the capsule and synovial membrane beneath the anterior and posterior acromion to check for injury or arthritis. Tenderness and effusion suggest glenohumeral joint synovitis. If the margins of the capsule and synovial membrane are palpable, a moderate to large effusion is present. Minimal synovitis cannot be detected on palpation. Range of motion and maneuvers. The 6 months of the shoulder girdle are flexion, extension, abduction, adduction, and internal and external rotation. Standing in front of the patient, watch for smooth fluid movement as the patient performs the motion listed on the table below. Learn the specific muscles responsible for each motion. Note the clear, simple instruction that prompt the requested patient response. Test muscle strength. Restricted range of motion occurs in bursitis, capsulitis, rotator cuff tear, and sprains and tendinitis. Note the test pure glenohumeral motion. The patient should raise the arms to the shoulder level at 90 degrees, with palms facing down to test the scapulothoracic motion. The patient should turn the palms up and raise the arms an additional 60 degrees. The final 30-degree test combined glenohumeral and scapulothoracic motion. The examination of the shoulder often requires evaluation for specific motions and structures. There are a few more than 150 different maneuvers for testing shoulder function, but few are well studied. Although performing these maneuvers takes supervision and practice, they increase the likelihood of identifying shoulder pathology. Rotator cuff disorders are most common cause of shoulder pain in primary care. Compression of the rotator cuff muscle and tendon between the head of the humerus and the acromion causes impingement signs or pain during shoulder movement. 5 maneuvers that have best LDRs and narrowest confidence intervals are currently recommended, 58 to 60. 1 pain provocation test, 3 strength test, and 1 composite test. In composite test, the patient experiences either pain or weakness during maneuver. Most of the data of these tests come from specialty practice settings but remains useful for general care. Pain provocation test, Near-Hawkins test, strength test, and composite tests will be shown in the video later. An age of 60 years and above and a positive drop arm test are the findings most likely to identify a degenerative rotator cuff tear with positive likelihood ratio of 3.2 and 2.9 to 5.0 respectively. The combined findings of supraspinatus weakness, infraspinatus weakness, and a positive impingement sign increase the likelihood ratio of a tear to 48.0 when all three are absent. The likelihood ratio falls to 0.2, virtually ruling out the diagnosis. This picture shows several tests that are going to be shown in the video later. So internal rotation, external rotation, maneuvers for examining the shoulders. Pain with adduction is a positive test with a positive likelihood ratio of 3.7. Acromioclavicular joint tenderness and compression tenderness have low likelihood ratio and are not diagnostically helpful. Pain during this maneuver suggests a rotator cuff disorder or adhesive capsulitis. Shoulder pain from 60 degrees to 120 degrees is a positive test for a subacromial impingement or rotator cuff tendinitis disorder, with a positive likelihood ratio of 3.7 and a helpful negative likelihood ratio of 0.36. So the maneuver or type of test, near impingement sign, also each table shows every test, and the pain during the maneuver is a positive test for a specific disorder, which are explained in the slides.
Hello everyone, I will be discussing about the wrist and hands. First would be inspection. First, we must assess the position of the hands in motion. Normal signs indicate movements are smooth and natural. Fingers are slightly flexed and aligned almost in parallel, while abnormalities indicate guarded movements that may suggest injury. Poor finger alignment would suggest flexor tendon damage. The flexor tendon is responsible for bending our fingers, so damage to it may lead to inability to bend our fingers or thumb. Next is to inspect the palmar and dorsal surfaces of the wrist and hand carefully for swelling over the joints. Abnormalities would be diffuse swelling, which may indicate arthritis or infection, localized swelling or ganglia, which could indicate ganglia from cystic enlargement. For the cystic enlargement, it is usually a non-tender swelling located along the tendon sheets or joint capsules. The dorsum of the wrist is a frequent site of involvement. Flexion of the wrist makes ganglia in this location more prominent. Extension tends to obscure them. It may also develop elsewhere on the hands, wrist, ankles, and feet. Next is to note any deformities of the wrist, hand, finger bones, as well as angulation from the radial and ulnar deviations. Abnormalities may indicate osteoarthritis and rheumatoid arthritis. Osteoarthritis can have Herberdens nodes at the DIP joints, Bouchard joints at the PIP joints. While rheumatoid arthritis is symmetric deformity in the PIP, MCP, and wrist joints with ulnar deviations. DIP would indicate the distal interphalangeals, PIP would be the proximal interphalangeal, while MCP would indicate the metacarpals. Next is to observe the contour of the palm, namely the thenar and hypothenar eminences. Abnormalities would be the thenar atrophy with the median nerve compression from carpal tunnel syndrome. Hypothenar atrophy would be from ulnar nerve compression. Pictures are already shown in this slide. Next would be to note any thickening of the flexor tendon or flexion contractures in the fingers. This would indicate Dupuytren's contractures. Flexion contractures in the ring, fifth, and third fingers and may arise from the thickening of the palmar fascia. The first sign of the contracture is a thickened plaque overlying the flexor tendon of the ring finger and possibly the little finger. Subsequently, the skin in this area puckers and a thickened fibrotic cord develops between palm and finger. Flexion contracture of the fingers may gradually ensue. Next would be palpation. Palpate the distal radius and ulna on the lateral and medial surfaces. Abnormalities would be tenderness over the distal radius, which would indicate Cole's fracture. Any tenderness, bony step-off are suspicious for fractures. A picture indicates the different types of fracture. Cole's fracture, which is known to be outward, and Smith's fracture, which is known to be inward. Next is to palpate the distal radius and ulna on the lateral and medial surfaces. The abnormality indicated would be rheumatoid arthritis, which will have bilateral swelling and their tenderness for several weeks in duration. Another one would be the gonococcal infection. May involve wrist joints, which indicates arthritis, or the tendon sheets at the wrist, which could indicate gonococcal tenosynovitis. Next would be to palpate the anatomic snuff box. The snuff box would be a hollow depression just distal to the radial styloid process, formed by the abductor and extensor muscles of the thumb. So its abnormality would be the tenderness over the snuff box, which should indicate scaphoid fractures. Next would be is to compress the MCP joints. Abnormality is painfulness with pressure. This would suggest synovitis. MCP is also boggy or tender, can indicate rheumatoid arthritis, and rarely in osteoarthritis. Squeezing the hand from each side between the thumb and fingers, alternatively, use your thumb to palpate each MCP joint just distal to and on each side of the knuckle as your index finger feels the head of the metacarpals in the palm. Note any swellings, bodginess, or tenderness. Procedures will be shown through a video at the end of this discussion. Next is to examine the fingers. Palpate the medial and lateral aspects of each PIP. Joint between your thumb and index finger, again checking for swelling, bodginess, bony enlargement, or tenderness. Using the same techniques, examine the DIP joints. Abnormalities would be the PIP changes seen in rheumatoid arthritis, Bouchard nodes in the osteoarthritis, and Hebergen's nodes, which is most common also in osteoarthritis. Next is to palpate along the tendons inserting on the thumb and fingers. Abnormalities would indicate tenosynovitis, which is the inflammation of tendon sheets, De Quervain's tenosynovitis, which is over the extensor and abductor tendons of the thumb as they cross the radial styloid. Next would be range of motion and maneuvers. Flexion. With the patient's forearm stabilized, place the wrist in extension and place your fingertips in the patient's palm. Ask the patient to flex the wrist against gravity, then against graded resistance. For extension, with the patient's forearm stabilized, place the wrist in flexion and put your hand on the patient's dorsal metacarpals. Ask the patient to extend the wrist against gravity, then against graded resistance. For ulnar and radial deviation, with palms down, ask the patient to move the wrist laterally and medially. For flexion and extension of the fingers, ask the patient to make a tight fist with each hand, thumb across the knuckles, and then extend and spread the fingers. The fingers should close and open smoothly and easily. At the MCPs, the fingers may extend beyond the neutral zone. Also test flexion and extension at the PIP and the DIP joints. For abduction and adduction of the fingers, ask the patient to spread the fingers apart, which is abduction, and back together as adduction, then check for smooth coordinated movements. This is a picture of the flexion, extension, abduction, and adduction, and also opposition. Next would be the spine. For inspection, assess the patient for erect position of the head, smooth coordinated neck movement, and ease of gait. Abnormalities would be neck stiffness, which would indicate arthritis and muscle strain. Patient should be upright in the patient's natural standing position. With feet together and arms hanging at the sides, the head should be midline in the same plane as the sacrum, and the shoulder and pelvis should be level. Abnormalities may include lateral deviation and rotation of the head. This could be known as torticollis, or the contraction of the sternomastoid muscle. Next to be inspected is the spinal curvatures. Any abnormalities would be the increased thoracic kyphosis that occurs with aging. That is the extensive or exaggerated curvature of the spine. Next abnormality would be the lateral and rotary curvature of the spine to bring the head back to the midline. This could indicate scoliosis. Unequal shoulder height would be known as Sprangel's deformity. Unequal height of the iliac crest or the pelvic tilt may indicate unequal lengths of the legs. Other abnormalities would be birthmarks, port wine stains, hairy patches, and lipomas. These are often overlay defects that may indicate spina bifida, which is a birth defect due to the neutral tube. It occurs when the vertebra doesn't form properly around the baby's spinal cord. Other abnormalities would be café au lait, spots, and fibrous tumors, which could indicate neurofibromatosis. Now to palpation. From a sitting or standing position, palpate the spinosus process of each vertebra with your thumb. Tenderness may suggest fracture or dislocation or underlying infection that could lead to arthritis. In the neck, also palpate the facet joints that lie between the cervical vertebra, about 1 inch lateral to the spinous process of C2 to C7. Tenderness occurs with arthritis, especially at the facet joints between C5 and C6. In the lower lumbar area, check carefully for any vertebral step-offs to determine if one's spinous process seems unusually prominent or recessed in relation to the one above it. Identify any tenderness. This could indicate spondylolisthesis, which is one bone in the vertebra slides forward over the bone below it. Next is to palpate over the sacroiliac joint. Ankylosing spondylitis may produce sacroiliac tenderness. It is often identified by the dimple overlying the posterior superior iliac spine. You may wish to percuss the spine for tenderness by thumping, but not too roughly with the ulnar surface of your fist. Pain on the percussion may arise from osteoarthritis. Pain on percussion may arise from osteoporosis, infection, or malignancy. Inspect and palpate the paravertebral muscles for tenderness and spasms. Muscles in spasm feel firm and knotted and may be visible. Spasm occurs in the degenerative and inflammatory processes of muscles, prolonged contraction from abnormal posture, and anxiety. With the hip flexed and the patient lying on the opposite side, palpate the sciatic nerve, the largest nerve in the body, consisting of nerve roots from L4, L5, S1, S2, and S3. Sciatic nerve tenderness suggests a herniated disc or mass lesion, impinging on the contributing roots. Next would be range of motion and maneuvers. So we have flexion by touching the chin to the chest. Extension, look up at the ceiling. Rotation, turn the head to each side looking directly over the shoulder. Lateral bending, tilt the head touching each ear to the corresponding shoulder. Tenderness, loss of sensation, or impaired movement warrants careful neurologic testing of the neck and upper extremities. Range of motion in the spinal column. Flexion. Ask the patient to bend forward to touch the toes or flex. Note the smoothness and symmetry of movement, the range of motion, and the curve in the lumbar area. As flexion proceeds, the lumbar concavity should flatten out. Deformity of the thorax and forward bending is found in scoliosis. Persistence of lumbar lordosis suggests muscle spasm or ankylosing spondylitis. For extension, rotation, and lateral bending, these can also be seen or explained further in the video. So this is a picture of the following exams for the range of movement. Next would be the hips. Inspection. Stance. When the foot is on the ground and bears weight 60% of the walking cycle. Swing. When the foot moves forward and does not bear weight, this would be the 40% of the walking cycle. Observe the gait for the width of the base, the shift of the pelvis, and the flexion of the knee. A wide base suggests cerebral disease or foot problems. Hip dislocation, arthritis, or adductor weakness can cause the pelvis to drop to the opposite side, producing a waddling gait. Lack of knee flexion interrupts the smooth pattern of the gait. Observe the lumbar position of the spine for slight lordosis, and with the patient's spine, assess the length of the legs for symmetry. Inspect the anterior and posterior surfaces of the hip for any areas of muscle atrophy or bruising. Loss of lordosis may reflect paravertebral spasms. Excess lordosis suggests a flexion deformity in the hips. Changes in leg lengths are seen in abduction or adduction deformities and scoliosis. Leg shortening and external rotation suggest hip fractures. Next would be palpation. With the patient supine, ask the patient to place the heel of the leg bending examined on the opposite knee. Then palpate along the inguinal ligament, which extends from the anterior superior iliac spine to the pubic tubercle. Bulges along the ligament may suggest an inguinal hernia or on occasion an aneurysm. Enlarged lymph nodes suggest infection in the lower extremity or pelvis. Tenderness may be due to synovitis of the hip, joint, bursitis, or possibly psoas abscess. Next, with the patient resting on one side and the hip flex internally rotated, palpate the trochanteric bursa lying over the greater trochanter. Normally, the ischio-gluteal bursa over the ischial-tuberosity is not palpable unless inflamed. Swelling with tenderness suggests trochanteric bursitis. Tenderness without swelling on the posterolateral surface of the greater trochanter suggests localized tendinitis or muscle spasms from referred hip pain. Tenderness and swelling in the ischio-gluteal bursitis or as they call it Weaver's bottom, because of the adjacent sciatic nerve. This may mimic sciatica. Next is range of motion and maneuvers. Flexion with the patient's supine. Place your hand under the patient's lumbar spine as the patient to bend each knee in turn up to the chest and pull it firmly against the abdomen. Inflection deformity of the hip, as the opposite hip is flexed with the thigh against the chest. The affected hip does not allow full leg extension, and the affected thigh appears flexed. Next is extension. With the patient's lying face down, extend the thigh towards a restricted abduction is common in hip diseases from osteoarthritis. As the procedure for abduction is to stabilize the pelvis by pressing down on the opposite anterior superior iliac spine with one hand. With the other hand, grasp the ankle and abduct extending leg until you feel the iliac spine move. This movement marks the limit of hip abduction.
I'll be discussing about the ankle and foot. First is inspection. Observe all surfaces of the ankles and feet, noting any deformities, nodules, swelling, calluses, or corns. I'll be discussing first is the abnormalities of the feet. Acute gouty arthritis. It is easily mistaken for a cellulitis. It is characterized by a very painful and tender, hot, dusky red swelling that extends beyond the margin of the joint. The metatarsophalangeal joint of the great toe is the initial site of attack in 50% of the episodes of acute gouty arthritis. The ankle, tarsal joints, and knee are also commonly involved. Next is flat feet. Flat feet may be apparent only when the patient stands, or they may become permanent. The longitudinal arch flattens so that the sole approaches or touches the floor. Tenderness may be present from the medial malleolus down along the medial plantar surface of the foot. Swelling may develop anterior to the malleoli. Flat foot may be the normal variant or arise from posterior tibial tendon dysfunction, seen in obesity, diabetes, and prior foot injury. The normal concavity on the medial side of the foot becomes convex, as seen in the picture. Inspect the shoes for excess wear on the inner sides of the soles and heels. Next is hallux valgus. There is a lateral deviation of the great toe and enlargement of the head of the first metatarsal on its medial side, forming a bursa or bunion, which may become inflamed. Women are 10 times more likely to be affected than men. Next is Morton's neuroma. Symptoms include hyperesthesia, numbness, aching, and burning from the metatarsal heads into the third and fourth toes. Check for pain radiating to the toes when you press on the plantar interspace and squeeze the metatarsals with your other hand. Next is abnormalities of the toes and soles. First is ingrown tail. A tender, reddened, overhanging nail fold, sometimes with granulation tissue and purulent discharge. The great toe is most often affected. Next is hammer toe. It is characterized by a hyperextension at the metatarsophalangeal joint with flexion at the proximal interphalangeal joint. It most commonly involving the second toe. Third is corn. A corn is a painful conical thickening of skin has resulted from recurrent pressure on normally thin skin. The apex of the cone points inward and causes pain. Corns characteristically occur over bony prominences such as the fifth toe. Next is palpation. With your thumb, palpate the interior aspect of each ankle joint, noting any bogginess, swelling, or tenderness. Localized tenderness in the ankle joint is often present in arthritis, ligamentous injury, or infection of the ankle. Next is feel along the Achilles tendon for nodules and tenderness. Check for rheumatoid nodules and tenderness, commonly found in Achilles tendinitis, bursitis, or partial tear from trauma. Next, palpate the heel, especially the posterior and inferior calcaneus and plantar fascia for tenderness. Bone spurs may be present on the calcaneus. Focal heel tenderness on palpation of the plantar fascia suggests plantar fasciitis seen in prolonged standing or heel strike exercise and also in rheumatoid arthritis and gout. Palpate for tenderness over the medial and lateral malleolus, especially in cases of trauma. Tenderness along the posterior medial malleolus suggests posterior tibial tendinitis and causes flat feet. After trauma, inability to bear weight after 4 steps and tenderness over the posterior aspects of either malleolus, especially the medial malleolus, is suspicious for ankle fracture, known as the Ottawa ankle rule. Palpate the metatarsophalangeal joints for tenderness. Compress the forefoot between the thumb and fingers. Exert pressure just proximal to the heads of the first and fifth metatarsals. Tenderness and compression is an early sign of rheumatoid arthritis. Acute inflammation of the first metatarsophalangeal joint suggests gout. Palpate the heads of the 5 metatarsals and the grooves between them with your thumb and index finger. Place your thumb on the dorsum of the foot and your index finger on the plantar surface. Pain and tenderness called metatarsalgia occurs in trauma, arthritis, vascular compromise. Tenderness over the 3rd and 4th metatarsal heads on the plantar surface signals Morton's neuroma. Forefoot abnormalities like hallux valgus, metatarsalgia, and Morton's neuroma are more common in women who wear high-heeled shoes with narrow toe boxes. Next is the range of motion. Assess flexion and extension at the tibio-talar or ankle joint. In the foot, assess inversion and inversion at the subtalar and transverse tarsal joints. First is the ankle flexion. Primary muscles affecting this is gastrocnemius, soleus, plantaris, tibialis posterior. You have to instruct your patient to point their foot toward the floor. That is plantar flexion. Next is ankle extension. Primary muscles affecting are tibialis, anterior extensor digitorum longus, and extensor hallucis longus. You have to ask your patient to point your foot toward the ceiling or do dorsiflexion. Next is inversion. Primary muscles affecting these are tibialis posterior and anterior. You have to ask your patient to bend your heel inward. Lastly, inversion. Primary muscles affecting these are peroneus longus and brevis. You have to ask your patient to bend your heel outward. Next is maneuvers. For the ankle joint, dorsiflex and plantar, flex the foot at the ankle. Pain during movements of the ankle and the foot helps to localize possible arthritis. The subtalar joint stabilize the ankle with one hand, grasp the heel with the other, and invert the foot by turning the heel inward and outward. An arthritic joint is frequently painful when moved in any direction, whereas a ligamentous sprain produces maximal pain when the ligament is stretched. For example, in a common form of sprained ankle, inversion and plantar flexion of the foot cause pain, whereas inversion and plantar flexion are relatively pain-free. To check the transverse tarsal joint, stabilize the heel and invert the forefoot. For the metatarsophalangeal joint, move the proximal phalanx of each toe up and down. Pain suggests acute synovitis, instability occurs in chronic synovitis, and cloto deformity. Measuring the length of legs. If you suspect that the patient's legs are unequal in length, measure them. Get the patient relaxed in the supine position and symmetrically aligned with legs extended. With the tape, measure the distance between the anterior superior iliac spine and the medial malleolus. The tape should cross the knee on its medial side. Unequal leg length suggests scoliosis. For the summary of my report, I'll be showing a video about the physical examination of the ankle and foot.
So today I will discuss about the knee and lower leg and the special techniques. So to start, we start with the knee and lower leg. inspection, observe the gait for a smooth, rhythmic flow as the patient enters the room. The knee should be extended at the heel strike and flexed at all other phases of swing and stance. Check the alignment and contours of the knees. Observe any atrophy of the quadricep muscles. Look for loss of the normal halos around the patella, a sign of swelling in the knee joint and suprapatellar pouch. Note any other swelling in or around the knee. So I have the video to show you the different kinds of gaits. Next is the abnormalities. Stumbling or pushing the knee into extension with the hand during heel strike suggests quadricep weakness. So the photo shows you the different phases of the normal gait cycle. Next is the abnormality on the legs. Bow legs, or also called as genu varum, and knock knees, also called as genu valgum, are common. Flexion contracture or inability to extend fully in limb paralysis. Next is prepatellar bursitis. It is an inflammation of the bursa in the front of the kneecap or patella. It occurs when the bursa becomes irritated and produces too much fluid, which causes it to swell and put pressure on the adjacent parts of the knee. So you can see at the right picture, the right knee is swollen. For the left picture, it shows the treatment for prepatellar bursitis, where we inject the needle to drain the fluid. Palpation. We do this while the patient is sitting down with the knees flexed. So place your thumb on the soft tissues depression on either side of the patellar tendon. On the medial aspect, move your thumb upward and downward and identify the medial femoral condyle, and on the upper margin, medial tibial plateau. Distally to the tibial tubercle. Posteriorly, the adductor tubercle. Then, palpate the ligaments, borders of the menisci, and the bursae of the knee, paying special attention to any areas of tenderness. Pain is common complaint. For the abnormality, partial or complete tear of the patellar tendon. Next, palpation. Well, the patient is in supine position and the knee extended. Push the patella against the underlying femur, then ask the patient to tighten the quadriceps. Check for smooth sliding motion. This test is also called as patellofemoral grinding test. So we check for pain and crepitus. For the abnormality, pain and crepitus suggest roughening of the patellar undersurface that articulates with the femur. It also suggests chondromalacia or degenerative patella. Then, flex the patient knee about 90 degrees. Palpate the cord-like lateral collateral ligament, or also called as LCL, between the lateral femoral epicondyle and the fibular head. For the abnormality, MCL tear or LCL, but lesser subject to injury. Then note any irregular bony ridges along the joint margin. So we check for osteoarthritis. Next, abnormalities, chondromalacia or degenerative patella. It shows that on the picture, on the upper part, the normal knee alignment. Then below, we can see the abnormal alignment of the patella with osteoarthritis. While on the right picture, you can see the MCL or LCL tear. Another kind of abnormality is the osteoarthritis, where the patient experiences pain, stiffness, hard swellings, soft swellings caused by extra fluid in the joint, and crepitus or cracking, crunching, grinding sensation when you move the joint. Osteoarthritis is the degeneration of the articular cartilage of the knee. Then, try to feel any thickening or swelling on the suprapatellar pouch along the sides of the patella, 10 centimeters above the superior border of the patella, and feel the soft tissue between your thumb and fingers. So we check for the synovial thickening or effusion of the knee joint. Then, check the 3 other bursae for bugginess or swelling. We check for the prepatellar bursitis or the housemaid knee, excessive kneeling, anserine bursitis from running, popliteal or Baker's cyst from distension of gastrocnemius semimembranous bursa. These are the pictures for prepatellar bursitis or the housemaid knee, synovial thickening or effusion of the knee joint, popliteal or Baker's cyst. For the popliteal or Baker's cyst, the patient experienced pain in the knee, inability of flexing the knee and stiffness, reduced joint flexibility. It is a round-shaped or golf ball-sized swelling behind the knee. Bulge sign for minor effusion. A fluid wave or bulge on the medial side between the patella and the femur is considered a positive bulge sign consistent with an effusion. Balloon sign for major effusion. When knee joint contains a large effusion, suprapatellar compression ejects fluid into the spaces adjacent to the patella. A palpable fluid wave signifies a positive balloon sign. A returning fluid wave into the suprapatellar pouch confirms effusion. Ballotting the patella confirms large effusion. Palpable patellar creak with compression may also occur, but yields false positive. Range of motion and maneuvers. Abduction, partial tear of the middle collateral ligament or ligamentum's laxity. Adduction, pain or gap in the lateral joint line points to ligamentous laxity and a partial tear of the lateral collateral ligament. Anterior drawer sign, anterior cruciate ligament or ACL, a few degrees forward are normal if in both sides are present. A forward jerk showing the contours of the upper tibia is positive in anterior ACL and anterior drawer sign. Latchman test, significant forward excursion indicates an ACL tear. Posterior drawer sign. Posterior cruciate ligaments or PCL, isolated PCL are rare. McMurray test, medial meniscus and lateral meniscus. A click or pop along the middle point with valgus stress, external rotation and leg extension suggest a probable tear of the posterior portion of the middle meniscus. Palpation. Palpate the gastrocnemius and sulcus muscles. So we check for tenderness and swelling and thickening. Achilles tendinitis. Squeeze the calf and watch for a planar flexion at the ankle. Pain like a gunshot wound in Achilles tendinitis. For special techniques, we do this for carpal tunnel syndrome. So the carpal tunnel syndrome The median nerve is compressed at the wrist, resulting in numbness or pain. So you can see at the bottom picture the part of the hand where it experienced numbness and pain. These are the special techniques for carpal tunnel syndrome. Thumb abduction, abductor pollicis brevis. Ask the patient to raise the thumb perpendicular to the palm as you apply downward pressure on the distal phalanx. Tinel sign. When the therapy stops over the carpal tunnel, the patient will feel electric sensation or tingling. Phalanx test. Holding the patient wrist in acute flexion towards each other's back of the hand for 1 minute. If numbness and tingling develop, it is positive to carpal tunnel syndrome.